So the intent of this last 15 minutes, 20 minutes or so to have you talk with your colleagues from your institution about this work plan was to give you time to begin to talk with each other about this work plan. I know how it is. You get so busy and you're doing all the things you do that sometimes that you don't get any time to reflect on the new information that you've heard. So our intent was not that you finish your work plan today, but that you get a chance to dig in a little bit, begin to have the conversation, and then this will definitely need to go further. But for those of you who have not seen the Baby Friendly USA tools yet, this is just one example of the many, what I think really fine tools it is that they have for us. So now I'm going to transition into talking about data and the Joint Commission's Perinatal Care Core Measure on exclusive breast milk feeding. And as I said before, I do not represent the Joint Commission. What I can do is represent the things that we've heard and my studying of the topic, as well as listening to someone to come from the Joint Commission to our California Breastfeeding Summit last January. So that's what I'd like to share with you. So what does the Joint Commission want us to do? They have told us that if we have 1,100 or more births a year, that starting with January 1, 2014, we will be reporting the Perinatal Care Core Measure set data to the Joint Commission. Excuse me. So if you're less than 1,100 births a year, does this mean you're off the hook? No, because it will roll out to all maternity care facilities. It will. It's just mean for 2014. And for the first 6 months of 2014, you are off the hook. The Joint Commission does revise all of their core measures on a very routine kind of basis, and every 6 months we could have new guidance from them. I expect next month, in October, we will have some revisions to even this work, even though it's fairly new. So in the Perinatal Care Core Measure set, there are 5 or 5.5, if you like to count them that way, measures. There were many more than that, 23 that the National Quality Forum looked at and suggested to Joint Commission that they consider. When they first, in 2010, started to roll this out, there were 7, then it was honed to 5. So it's very much, the Joint Commission is a fluid and dynamic organization because our work is changing all the time. Our evidence base is changing. So right now, these are the perinatal care core measures that we are to report on starting in January. We're going to start right now, this next part of the presentation, just talking about PC 05, exclusive breast milk feeding. So it's all newborns, and it's, a newborn receiving only breast milk and no other liquids is considered an exclusively breast milk fed baby. So we do get to not need to consider those babies who've had medications, minerals, vitamins. Those things do not count. If it's an exclusively breastfed baby who does get an oral medication, he's still an exclusively breast milk fed baby. And it's also that we now count mother's expressed milk as well as donor milk. So it isn't a breastfeeding core measure, it's a breast milk feeding core measure. So especially for me, a lactation consultant for a long time, it's hard not to say breastfeeding. I have to catch myself all the time. This is a breast milk feeding core measure. So we do get to count those mothers who are expressing their own milk for their own babies, and those mothers who are using donor milk. Oops. Went the wrong way. There we go. So if we actually get down to the math, what does the numerator and the denominator look like? In our numerator, we've got the number of our term singleton newborns who have been fed only breast milk since birth. And as Karen said, strictly interpreted, it's the pediatric note that can and should be used for this. There are many hospitals, though, that I know use the medical record and query the stay. So then really it's giving data to the pediatrician, whose note is the final word. But we can use data to support the pediatric documentation. And it's term babies, so our late preterms are excluded, as well as some others. So in the denominator then, we've got all our term singletons discharged from the hospital entirely of the non-excluded categories. So the excluded categories are babies who have a NICU stay, babies who have galactosemia, which we don't know while they're in the hospital, but If we did, we get to exclude them. Babies who are on TPN, babies who have passed away, babies who have stayed with us longer than 120 days, and those enrolled in clinical trials. So those are the baby exclusions. And often then this begs the questions, well, what about the NICU? What about the NICU? The drive-by NICUs don't count. The babies that go to the NICU that have complex medical issues, that have had care that's provided there, are babies that get to be excluded. But if you do have a drive-by situation, a baby who's just there for a little observation and then back out with his mom, you need to include him in your denominator. You don't exclude him. Okay. And what does the joint? Yes, please do.
We're a very small hospital.
Yes.
And we don't have a NICU.
Right.
So we transfer.
You transport your sickest babies.
So those are kind of drive-by through our nursery. Do those get excluded, or I'm not sure?
Yes, because yes, they do get excluded. They were not discharged from your hospital from your normal newborn service. They're discharged from some other hospital from the NICU service.
Okay, thank you.
Yes, glad you asked. So the Joint Commission wants to see us improve this number over time. More exclusive breast milk feeding for babies. That's the goal. So that right now there's not a national benchmark or standard. And that's different from some of the other core measures. For example, with the antenatal steroids, it needs to be 100%. That's the number the goal is. And for the cesareans before 39 weeks, it needs to be 0. I mean, there's a clear standards. We don't have a clear standard yet in breastfeeding, breast milk feeding. We are charged now with increasing over time. The documented reasons for not exclusively breast milk feeding babies. So when breastfeeding and breast milk feeding is contraindicated, we need to document that, and the Joint Commission has a short list of maternal reasons that breastfeeding should be avoided, and as you can tell, these are all maternal reasons. Long list. Not quite as long as list as baby friendly, so if you have a conflict in looking at the the baby friendly's guidelines and evaluation criteria from this is what Joint Commission's asking us to do. And this is the more tougher standard, but the standard that we can and should be using. So then it's really, documentation. If it didn't get documented, it didn't happen. And I know in my lunch breakout we were talking about data, and this is one of our biggest challenges, is that we don't always get consistent, reliable documentation in the medical records. So this is a constant challenge for us in many ways, but with this one in particular, we want to be sure that we take a look at this. And then when we go on further to look at PCO5A, and this is the exclusive breast milk feeding, considering the mother's choice. So first of all, why did this come about? The National Quality Forum is a body of experts. Some of them are federal partners, some of them academians, some of them people in industry, and the people in industry that came to the table was the Infant Formula Council. And they were able to sway the National Quality Forum and then in turn Joint Commission to include this measure. And at that time, the United States Breastfeeding Committee was not at the table. So this got in there. Now, I don't think it's all bad, and I'll show you why, but I also want to tell you that it's fuzzy and it will probably change this fall. So go on just a little bit what it is. So right now, that if the mother chooses not to breastfeed at admission, then she is not included in the denominator in this. And it does need to be clearly documented in the medical record. So the formula looks like this. It's the same numerator now, but a smaller denominator, because now we get to exclude those mothers who chose not to breastfeed at admission. So here's a couple of examples, things to think about. Our healthy term who gets dehydrated from poor milk transfer, can we exclude him? No, because he doesn't have a maternal condition, and it's not contraindicated for him to breastfeed. He didn't do it well, so he's in there. The healthy term for infant who gets supplemented with expressed milk or donor milk is included. He's not breastfeeding, but he's being breast milk fed. So if we go through a hypothetical, we just made up these numbers, but we wanted to bring it to a situation where we could compare numbers. So let's say there were 200 births, and we had 20, oh my God, but 20 substance abuse mothers, 5 with HIV, 4 that were not full term, 10 who were multiples, and 5 spent some time in the NICU. And I know these numbers are skewed. Probably should flip the other way, have more in the NICU, but there we are. So now we have this denominator of 150. We've removed the excluded, the acceptable excluded ones. And then of those mothers in the denominator, 50 just didn't want to breastfeed. 20 wanted to breastfeed but got formula later at mother's request. 10 get formula for a medical reason. So now we get to subtract these, and our numerator is 70. So if we look at what our final percentage is, 70 over 150, or 47%, which is about our average in our county right now, just to give you an idea where we are with this Joint Commission number, which is way better than we used to be. Now, what if we're also looking at this hospital, but with PCO5A? So now we're considering the mother's choice. We've got still these same mothers who are excluded from the denominator, so our denominator remains the same, 150. Excuse me, I think I said that wrong. That one. Yeah, denominator. Okay, denominator. And then of those in the denominator, the denominator doesn't remain the same. I'm not saying this very well. We get to the first step of calculating denominator in the very same way. So this denominator is the same as PCO5. Then we go to make it a smaller denominator because in PCO5A, we take out the mothers who are not going to breastfeed. So when we do that, we now have the denominator at only 100. We still have this 70 numerator, but now our denominator is smaller, so our number comes out higher, 70%. This is what the formula companies wanted, was high numbers, because if it's a high number, you don't worry about it, right? Okay, so, but I think they kind of shot themselves in the foot at this stage, because now we have a gap that we need to explain. So if only 47% of our mothers are exclusively breast milk feeding, and yet of those who chose, including those who chose not to, what does that tell us about the choice not to?
Prenatal education.
Prenatal education, exactly. If this tells us that this facility is not getting as many mothers prepared to say, yes, I want to breastfeed when she comes into the hospital. So we need to address this gap. We need to collect both and see what our gap is. Karen's gap, I think, was about 16 between the two. And there are different people around the planet who have said, what number should the gap be? I hear some people say only 5%, others say maybe 10%. 16 would be something I would still be wanting to work on and work at improving. But if we got down to 5, I'd probably say I think we're doing our job, you know, because we are going to have some recalcitrant moms in there and such. So that's PCO5A and B, and a little bit of the timeline was that many hospitals started collecting data in 2010 when it was optional. Some systems, Dignity in California, Catholic Healthcare West used to be their name, started collecting then. Kaiser did. Some smaller hospitals with forward-thinking nurse leaders with quality improvement backgrounds started collecting then. It was optional. In 2011, the core measure aggregate was released at that time. So one of the things that's pretty amazing about where Joint Commission is going is in the transparency. And just like so many other things in healthcare, public availability of the data is becoming more and more where we're going as an industry. So the transparency comes in qualitycheck.org. So it's really interesting. Who's gone on this website? Anybody in the room? Yay, a few. Good. That's probably only about a third of you. I encourage the rest of you to go there and see what is there now. Cesareans are already there, for example. So to see what data is being recorded on your hospital and on the hospitals that are neighboring to you, your hospitals that you consider who you benchmark yourself against, whether it's in this state or another state. And so starting in the third quarter of next year, so starting in January, we are all to report this data, and during the first 2 quarters, those data will be between the hospital and Joint Commission. Starting with the third quarter, so after July of next year, qualitycheck.org will have your hospital PCO 1 through 5 data on qualitycheck.org. That's the plan if you're larger than 1,100 births. So one of the things we should do is get ready now, because January will be here before we know it. some of the questions we have to ask ourselves as we're getting ready is, who is going to collect the data? Does our electronic health records support us to collect it query it in an automatic way? She's laughing. And then where are the data, and are the data being noted in a way that that you can harvest the data? Is it a free-form note? Is it a click? What is it? How is it being recorded currently? And then who in your facility can help guide us in maternity care on the number that we should be collecting? The Joint Commission has a formula based on the number of incidents that guides you. And a very, very large hospital, a 5,000 delivery rate hospital in our community, has shared with me that their QI people are saying that the Joint Commission needs them to collect 37 charts, I think there's 35, and they usually go for 40 or 45 so that they can feel like they have a robust enough data pool. But it's not all 5,000 births. It's not. There is a formula. If you're a very small hospital, it will be universal data collection that you will need to do, because your numbers are so small that in order to have it be statistically significant, you've got to have all the data. But the larger you are, the fewer by percentage that you need. How do we assess the mother's feeding preference at admission? So what are we asking her? Are we saying, do you want to do breast and bottle?
We hope not.
What are you saying? Do you want to do breast or bottle? Are we doing an open-ended question? How do you plan to feed your baby? What is it that we say so that we will get the information that's going to be supportive of breastfeeding and collect data in a way that's meaningful? And sometimes those don't feel like they're exactly in alignment. And who is it that asks the mom? Is it a clerical person? Is it a nurse assistant or tech? Is it a RN? Who is this? And then there are probably other questions that we have to ask ourselves gearing up for this. So I'd like to hear what you're thinking about as other things that we should be thinking about now, so we can share.
One of the things that the Joint Commission data collectors are telling me from my hospital, that it has to be documented by the physician or a lactation consultant on admission of the baby.
The feeding preference. So,
feeding
you were hearing that it needs to
feeding
be.
preference, yeah.
So that's an internal decision, as far as I.
It's the Joint Commission requirement.
They told us that too, that it is a Joint Commission requirement.
Interesting. Well, thank you. I will look that one up. What about a hospital that doesn't have any lactation consultant? Then it's incumbent upon the
It has to
physician.
be the physician,
So it's the
yeah.
admitting physician, the OB. That's interesting. I think in the long run you can make that work for you very well.
Well, yeah,
Thank
it's pretty
you.
easy. You just put it on their H&P or whatever, and they click the form.
It's easy, but it's also something that then gives you a track record for the OB, and that you can store a family practice doc, or midwife, who's ever providing the prenatal care. Yes?
Yeah.
Just a comment, it would be nice if Joint Commission addressed the reason why the mother is choosing to bottle feed, because so many of the reasons are based on misinformation. And so if we could kind of find out.
I think that is exactly what Joint Commission wants us to do, is figure out what is it we can do to change this situation and move these numbers. So for us to explore the reason, and that's the way Baby Friendly talks about it, is that when a mother asks for a bottle, asks for formula, whether it's her first time asking for it or whether she is, that she said, I want to bottle feed or formula feed only, or whether she started out with the intention to breastfeed and then changed. Either one of those mothers, Baby Friendly asks us to explore the reasons why, address her concerns, educate her. She may change her mind at that point. It's hard in labor to sometimes be changing your mind. But if we do that, if we explore, ask why. What are your concerns? What are they? Address those concerns, educate around that. And then if she still is saying she wants to use formula, we document that we've done those steps. So exploring the reason why is really, really valuable. Joint Commission isn't currently asking us for that, but it makes sense that we do that ourselves. And this is where the work that we're doing in Baby Friendly and the reporting to Joint Commission very nicely dovetail and overlap to support our moms and babies.
I'm sure everybody has an example of that mom who said she was going to bottle feed her baby when skin to skin and then self-attached, and she was like, oh, well, maybe I'm changing my mind now.
I know a hospital that was collecting data on intention to breastfeed and had their exclusive breastfeeding rates often paying higher than their intention to breastfeed, just because of that. If we put all babies skin to skin and help all mothers and babies bond, which is our goal, then we're going to have some babies that change their moms' minds. It is true. The moving on to what Baby Friendly USA requires, we need to use the guidelines and evaluation criteria document as our Bible. I actually meant to say this earlier and probably should have a sign with a something on it, but the guidelines and evaluation criteria, G and EC, the guidelines and evaluation criteria are where we look. What does Baby Friendly want us to do? It's all in the guidelines and evaluation criteria, and that's available to download wherever you are, whether you're not even in Discovery. It's free on their website, available to all of us, which is so different than during the Certificate of Intent pathway process 5 years ago, and none of us knew what we were supposed to be working toward. But now we do, the guidelines and evaluation criteria. So when we look to step 6, which is exclusive breast milk feeding, in step 6, what we are told to do is capture the data on exclusive breast milk feeding as defined by the Joint Commission. So if the Joint Commission changes, then we will change with that. Baby Friendly has exclusion criteria in their appendix that's different than the Joint Commission. So if there's a difference between Joint Commission and Baby Friendly, it's our interpretation that we should follow Joint Commission because the criteria, they say, is follow Joint Commission. So we've got a little bit of a misalignment right now. We've got Joint Commission exclusions, we've got Baby Friendly appendix solutions, but yet we've got this criteria that says follow Joint Commission. So we've been encouraging our hospitals, and they seem to be successful doing this, to follow the Joint Commission exclusion criteria as opposed to the Baby Friendly. So sometimes that means they're changing their data collection every 6 months when the Joint Commission is changing their data collection requirements. Not sometimes, always. And then Baby Friendly USA wants all hospitals to compare their internal Joint Commission definition of breast milk feeding data, their internal number, like 47 from my example there, and compare that to the supplementation rates that the CDC publishes that come from the National Immunization Survey. So on the CDC's website, under breastfeeding statistics, you can drill down and find the supplementation rate for Colorado. Okay, and that's the number to compare to for Baby Friendly. That's what they ask us to do. Then the third thing they ask us to do is also very similar to exactly what Joint Commission asks us, and that's to improve our rate in non-medically indicated supplementation. In other words, that mother's choice, grandma's choice, whoever's choice. You know, we want to increase the number of non-medically indicated supplementation. And also, an underlying side note is that many of us think that we also ought to be looking at our medically indicated supplementation over time. Also, what are we doing to cause a need for medical supplementation? How have we managed labor? How have we managed the peripartum period that maybe we're contributing to our own need for medical supplementation? So that's a side note and an area that a lot of people are working on, not specifically required by these guys, but one that makes sense to me. In our electronic health records, many people in my data session breakout at lunchtime commented on the fact that your vendor is very happy every 3 months or 6 months or a month, whenever you ask them to do another modification and take a fee for doing that modification. So we've had everybody reinventing the wheel everywhere. And a large vendor really has no motivation to, on their own, make a whole national system, given the way where we've been in the past. So it's a big challenge, and it's something that people do recognize around the nation. So a project that just was started this year, the CDC funded NICU to have a subcontract with Baby Friendly USA and the United States Breastfeeding Committee to convene a group to create guidelines on what and how the data can be queried in the national vendors packages. And now that Joint Commission has required this, we have federal partners that are supporting this as well, not just through the funding, the CDC, but the federal partners that are involved in National Quality Forum and also innovation and one other quality group that I can't remember the name of. So we've got this project coming. It's not here yet. We can't sit still and wait for it if we're on a fast track to baby friendly in anyone's place. But know that just as soon as it comes, people like Jennifer, who are well tied into what's happening nationally, will know about it first and be able to share it in Colorado, along with Marianne, who's also involved in the 10-state collaborative. And just in the last journal, in August journal of Human Lactation, Lori Feldman Winter and her colleagues published a commentary on the Joint Commission data, which really summarizes a lot of what I've just said. So if it's been kind of boring right after lunch listening to me, you can pull up their article, and it's also very dry but very accurate to explain this subject. And it may be helpful for you to take a journal article to your team, especially the team that's most concerned and involved in data collection, to really flesh this out. It's got layers. It's like peeling the onion. We have to get down to the nugget of the mother-baby breastfeeding, breast milk feeding. But in order to get to how do we collect the data and what we do, we've got a lot of details there. So I encourage you to take a look at that article. Which reminds me, several of you have asked Jennifer and others for my slides, and yes, they have them, and you will have them. Jennifer will push them out to you, and this kind of citation will be there, as well as that really cute YouTube with the little kids.
Yeah.
You'll have that link as well. It's a good one to share. There are more resources to support in addition to that last article that I mentioned. The Joint Commission itself is a very, very deep and rich website. I find it kind of daunting sometimes to drill down into it, but it's all there, and I'm looking up the admission thing that you guys just mentioned. I really appreciate being pointed in that direction. And the United States Breastfeeding Committee published a tool called Implementing the Joint Commission Core Measure on Exclusive Breast Milk Feeding. And the tool is divided into two pieces. The first half of the tool is all about the data, how to collect it, sample charting, really great ideas on dealing with the limited resources that we all have. Why reinvent the wheel? Look at the toolkit, grab ideas. The second half of the tool is about improving your exclusive breast milk feeding rate, which is really all baby friendly, again. And it's good. It's very, very good tool, and it's been kept up to date. It was modified when PCOA came on the scene, and it's very likely it'll be modified again in the future. So with that, I'd like to take a couple questions, and can we turn off the recording, please? Yeah. Questions? Yes.
I'm a little bit confused.